open the floor for questions. Kate? Yes.
Okay.
Yeah. So Alok, thanks for a lovely talk. I was wondering if you could comment more on interaction with the physicians, given your models, and also how that might evolve over time, right? So, for example, you were talking about intubation and extubation, but wasn't clear to me that the success rates, the predictions you had there, were actually given to the doctors at the time, and they made a different decision, right? How many explanations were included with those, and what needs to be included to get the physician's trust in the recommended decision? And also, as we go forward, new drugs and new treatments are identified, right? So how do we quantify or qualify the decision based on uncertainty factors like that?
Yeah. So your first question is that our interaction as a CS people with these guys or their interaction with patients? Which one are you talking about? The interaction question?
Your interaction with the physicians.
Yeah. So I think as we have spent now 3 years with them, working with them, in fact, I hired a PhD student who was interested in this just for this. And of course, one of my research professors spends 50% of his time. So we work very closely, right? I mean, poring over data. And so the interactions are, we share our knowledge, we learn from them. I would say 2-3 times a week. And one day full, so building relationships and interacting with them, because this requires working really deeply with them. Now, initial challenge was to understand their language. They talk about all sorts of, in medicine space. Yeah, I mean, if you know the names of just the drugs, you don't know. I mean, I've never understood why people give complicated names to drugs, right? Yeah. So understanding that was, so we build confidence amongst ourselves. We gone to foundations together to raise money and so on and so forth. So it is improving over a period of time, right? And when you explain to them, so it's not just the explanation of the results, right? We are working together to build the models themselves. And now, of course, there are people in life sciences who work with them. They are starting to develop these models. So there is a very good understanding of, we say, okay, we talk from AI ML perspective, what works, what doesn't, what are the challenges, and so on. So it's work in progress, but now we are very comfortable. They are so comfortable now. They are starting to, introduce us to other groups within the hospital and school of medicine and things like that. So, and what was your second question about?
Over time, how things evolve, right? So it's always fascinating to see how your science, for example, can impact actual practice.
So, in that first intubation and extubation model, right? The way you evaluate the decision is that, let's say you are making a decision today, model says extubate. Patient was extubated 5 days later in the real decision historically, right? So the model decision is good because it predicted way in advance that you can extubate the patient, right? So going through those cases, and then where patient was extubated and then had to be reintubated, well, model said, hey, keep it reintubated. Those are the types of things that give them a lot of confidence on using these, because now they say, yes, this would have been the right decision, because you can always observe what happened at the end. So, and that's why, I was showing you from left to right, extubate tomorrow, 2 days, 3 days, etc., right? So there are challenges, identifying the lab values, the variables which impact decision making, the model. Doctor has to say, okay, I know that this DLCO, I mean, I'm just using one of those ways, is indicator of something, and the model says it's indicator of something. So that's how you build confidence in that. So, and these are real, these guys, some of them during COVID working 24 hours a day in ICU, the COVID time. So they are doing transplants, they are doing ICU, etc., etc. Okay.
I have another question.
Yeah.
How, in comparison of any other area, imagine that you bring your knowledge, AI, into, I don't know, finance or any other problem, climate. How, again, everyone has his own terminology, other culture. Was this more time consuming, more difficult? Because I mean, in climate and weather, there is always life at stake as well. So did you feel more uncomfortable?
Yeah, I mean, and we have worked with climate people. In fact, we had an NSF center on climate modeling, a big NSF center. Well, I can talk about myself, and of course the challenges are different, right? Common people, everybody knows somebody, or everybody goes at least to do regular tests, or most of us, they know what doctors do, they know the challenge, so you can very easily explain what problem it's solving in the real, because all of us need interact with doctors, right? Climate is an abstract problem for most people. So that's the general population. Second is computer scientists and engineers. Hopefully they've taken physics and sciences. So it's easier to understand the problem formulation, that what you're predicting. There are physics models and there are chemistry models and all that you've learned. So it's easier to learn the problem specification, because what you're trying to predict the temperature or whatever for long term, for long term predictions versus weather, etc., etc. So this was the hardest for me to understand.
And we noticed. Because you share your pain.
Yeah. No, but it's been very interesting and challenging, and we can see the impact, and then we can see how things are going. And in fact, it's so strange that one of my closest friends has cancer and developed the lung problem. And I sent him my talk, and then he took that, to talk to doctors, say, etc., etc. So, and I started talking about SSC, ILD, etc. And they said, how do you know all that? So, and I said, okay, we are working on this research. So it is different and interesting for us.
Thank you very much.
Thank you.
And